Um, my name is Nancy Bagatelle, and I am the division director here at UNC. And we are going to be presenting this evening um, about that's how we do it, ethical tensions in occupational therapy. So I'm really pleased to be doing this presentation this evening with my colleague, Mary Beth Gallagher, who is on faculty at Duke. And so we're doing a blending of the blues this evening. Um, that's how we do it, right? We like to do collaborative work. And so Mary Beth and I have been working together for 5 or 6 years now, related to the information that we're going to be presenting this evening. So with that, we will go ahead and move forward. Um, this is our agenda for the evening. We will do a little bit of review of just what are ethics, and talk about our code of ethics, just to remind everybody about basic principles. And then we are going to be talking more specifically about ethical tensions in practice. We'll move to present some of our research findings related to the experience and of ethical tensions in practice. Throughout, we will actually be doing some reflecting as we move forward. So we will ask you periodically to either jot down on or in the chat your thoughts. And as we can, we will be asking you to unmute if we have time for that. At the end, we will have a question and answer period, and then we will end with the important piece of information about the QR code and link so that you can access a survey to get your certificate. So that is our agenda. Joining us also this evening is Sarah Pena, who is supporting us with tech. So thank you, Sarah, and Amy McElmore, who's our communications director in the Department of Health Sciences. So I think we are ready to launch.
All right. Well, I will kick us off, and thank you for inviting me to do this with you, Nancy. I'm really excited, and I'm really excited about the way that our research aligns with those ethical considerations that as practitioners enter our lives every day, and maybe we just don't stop to think about them very often. So I'm excited that this could be interactive and we get to hear your experiences as we share the experiences of the therapists who participated in our research. We kind of felt that a good ethics presentation should really start off with talking about what is ethics. So we went back to the dictionary, and you probably all know this by now, that ethics is a branch of knowledge that deals with moral principles or a set of moral principles, a theory or system of moral values. And it is these definitions that guide our occupational therapy code of ethics. The American Occupational Therapy Association Code of Ethics is a common set of values and principles, and it's designed to reflect the dynamic nature of the occupational therapy profession, the evolving healthcare environment, and emerging technologies that can present ethical concerns, practice, research, education, and policy. That's according to the AOTA 2020, and we are talking from the Code of Ethics AOTA 2020 this evening, knowing that it's reviewed every 5 years. And there's a pretty active debate right now, certainly on the ComOT chats, about the revisions to Ethics 2025. So maybe our next year's talk will be about that debate. But this year we're sticking with the Code of Ethics 2020. And it is comprised of aspirational core values and principles. And it outlines a commitment for occupational therapy practitioners to promote inclusion, participation, safety, and well-being for all recipients of our services. Those aspirational core values are altruism, equality, freedom, justice, dignity, truth, and prudence. I'm not going to define all of those for you. I think you're probably pretty familiar with what they mean, but it can be interesting to go back and read those just to refresh your memory, and maybe tonight even think about how those relate to your practice. We also have principles in our code of ethics that guide our decision-making and our action. And together, these principles and core values support the enforceable standards of behavior outlined in the AOTA Code of Ethics. So the AOTA Code of Ethics use those moral values and principles to enforce particular standards of conduct related to these areas of professional practice. So professional integrity, our therapeutic relationships, our documentation, our reimbursement and financial matters, our service delivery, our professional competence, our education, our supervision and training, our communications, and professional civility. So those are the areas in which we uphold these codes of ethics and which are enforceable, and there's a whole procedure should one of those be breached in practice. Beyond just a rote rules for conducting oneself in practice, AOTA Code of Ethics, says that ethical action is a manifestation of moral character and mindful reflection. So recognizing and resolving ethical issues is a systemic process, and it includes analyzing the complex dynamics of situations, applying moral theories and weighing alternatives, and making reasoned decisions and taking actions and reflecting on outcomes as we encounter some of our ethical decision-making in practice. But what happens when you engage in a systematic reflective process and you discover that maybe your believing of the right course of action isn't necessarily in alignment with the system in which you're practicing or the context in which you're practicing? It's in moments like these that we encounter ethical tensions.
So tonight we're going to talk about ethical tensions based on the work of DeRocher and colleagues that was published in 2016. They drew on the work of other scholars, particularly Jameson, to have three types of ethical tensions. The first one being ethical dilemmas, which are situations in which healthcare professionals face two mutually exclusive possible courses of action. So we can either treat or not treat, right? So they're dichotomous possibilities. Ethical distress are situations in which healthcare professionals are constrained from acting in the way that they believe to be most appropriate. And we're going to focus quite a bit on that this evening, along with this idea of ethical uncertainty, which are situations in which healthcare professionals are unsure if a situation is an ethical issue or not. So we will be presenting some situations that the practitioners that that participated with us in the study discussed. So ethical tensions, it's really important to remember that they can occur at sort of the micro level, at the individual level, or at the macro level, the systemic level. And it's the systemic level that we are going to focus most on this evening. So when we think about ethical tensions, again, distress, et cetera, and systemic constraints, some of the examples that DeRocher et al. Talked about in their study that took place in Canada that I think are pretty familiar to us as well here in the States. But they talked about insufficient resources, equipment, tools, excessive caseloads, cost containment, productivity demands that are very common in our healthcare system, as well as reduced length of stay. And so these are all situations that occur because of systems policies and procedures that really can cause practitioners a lot of ethical dilemmas and other forms of ethical tensions. So we thought we would pause here for just a quick minute and ask you if you would mind putting into the chat, what are some of the systemic constraints that you've experienced? And what impact have they had on you?
Nancy, we have productivity expectations, standards, poor school attendance for students, too large a caseload, compliance-based schools, insurance limitations, strong emphasis on risk-adjusted length of stay, lack of community resources, insurance reimbursement, seeing lots of productivity, health insurance not covering services, but families not being able to pay out of pocket, but services
Yep.
still medically necessary. There's more
Yeah,
insurance.
lots of ones. There's one about physicians' request to treat certain patients. It's a really interesting, important one as well. So yeah, lots of constraints that we experience in our everyday practices. So thank you for putting those in the chat.
I wondered if maybe people could address a little bit about the impact that's had. The second question.
The overwhelm, moral distress, takes away for caring for yourself, tasks falling, therapists that should not, taking away time from therapy, frustrating, draining, reduces quality of care, feeling pulled in many directions, transitioning out of traditional practice.
Yeah. Yeah. Well, thank you for sharing that. We will be talking about some of these as we move forward, but go ahead, keep putting them in. It's very interesting to see what people are experiencing in their everyday practices. All right, let me get this moving forward. So the effects that you all mentioned are, in fact, with ethical tensions and related systemic constraints have been reported in literature to contribute to professional burnout. I think we're all pretty familiar with professional burnout. There was a lot of discussion about professional burnout in healthcare workers during and after the pandemic. But some of those characteristics of burnout are emotional exhaustion, physical symptoms, cynicism, frustration, lack of motivation, insomnia, and fuzzy thinking. So it has very wide-ranging effects, as well as what within the occupational science literature is called occupational alienation, which is a form of occupational injustice. So occupational alienation, as described by Ann Wilcock, is a sense of isolation, powerlessness, frustration, loss of control, and estrangement from society or self as a result of engagement in occupation that does not satisfy inner needs. So most of the conversations about occupational alienation have been about what our clients or patients might experience. However, it's also important to think about this concept in terms of what practitioners experience. And so Wilding did a study in Australia with occupational therapists to look at their experiences. And what they found was that systemic structures that governing the workplace limit the agency of practitioners. And this results in a disconnection from their practice, particularly occupation-based practice, and the acceptance of dominant ideas that can contribute to this idea of hegemony. So you may be wondering what hegemony is, but hegemony, as defined by the philosopher Gramsci, who was a Marxist philosopher, talked about hegemony. Sorry, I'm trying to move the, the boxes so I can see the slides. Is the success of the dominant classes that to have their worldview and reality accepted by others as sort of common sense. So it's this idea that legitimizing certain norms and ideas that then become, as I said, sort of widely accepted without a lot of questioning of that. So it is a it's power, but it's not doesn't rely on force, but rather this sort of persuasion and passive acceptance. So hegemony in practice has been examined, particularly within medical models and in relation to physicians and nurses in particular, but we've also looked at hegemony in practice in occupational therapy. So again, Wilding looked at and talked about hegemonic practices that contribute to occupational therapy becoming sort of an invisible and subservient profession, which is what her participants in her study talked about. In a second study, Lowe et al. In Malaysia looked at in rehab settings, but really identified as this hegemony as a suppressor of occupational therapy that creates these occupational injustices. And again, not just for our clients, but for practitioners. So this leads to acceptance, as I said, and that's sort of the title of our talk. That's what we do here. That's how we do it here. And this idea that we come to just sort of accept various aspects of our practice because that's sort of what's happening in the system around us. So we were very curious to learn a little bit more about this. And so Mary Beth is going to now talk about the study that we did.
So at the time of the study, I was a practitioner in an acute mental health setting and experienced a lot of the same system constraints and impact that were present in the chat this evening. And so in really wanting to be more occupation-centered in practice, which again has been highlighted as difficult to do in a lot of systems, I embarked on a practice-based inquiry, and I went to the expertise of an academic and asked Nancy if she would join me in doing this research. And so we decided that, and I had read this paper on a practice-based inquiry, and I thought this was a very interesting methodology. So we'll talk about the practice-based inquiry as the methodology that we use to engage in this research. We'll talk about who the co-researchers were, and we'll talk about the data collection and the data analysis, and present our findings as responses, a varied range of responses to trying to practice in a very hegemonic biomedical risk-averse context. So practice-based inquiry is a type of action-oriented participatory research method, which means that the people you are researching are engaged in the research process with you. So we invited all of the practitioners who were working with me in the acute mental health setting to participate as co-researchers in this examination of our own practice. And based on kind of an iterative cycle of reflection, discussion, action, and reevaluation, you generate knowledge through these discussions that you then turn around and implement in practice. And then you review it and you start the whole process again. And as such, it has the potential to enhance or transform practice. And what we were hoping for was to become more occupation-centered or discover ways to become more occupation-centered in our practice. So we ended up having 9 occupational therapists, co-researchers, all in the acute mental health setting. They had 1 to 16 years experience of practice in mental health settings. And 4 of them were at advanced level practitioners. So they were clinical specialists in mental health. The data collection was documentations of daily practice. And so I need to give a big shout out. We need to give a big shout out to the co-researchers, because you can imagine all of those productivity constraints that you all mentioned, adding to that a daily reflection on practice, which was sometimes difficult to commit to, but they were asked to document their thinking, feeling, and doing about their practice. So as they went through their day, to kind of write down things that stood out about something that happened, about a feeling that came up for them, or about a session that went really well, or something that they really wanted to do, but then got up to the unit and found out they couldn't do that for some reason out of their own control. And so they documented these and then uploaded them into a shared drive so that all of the co-researchers had access to them. Additionally, we had bi-weekly reflexive discussion meetings that were recorded as a community of practice scholars. So as a group of people practicing in the same area who not only committed to work together to develop practice, but to engage in the process of research of our own practice. And so those were recorded. And then we discussed in those all of the reflections that had come up for us each week, and just kind of unpacked those. And as things arose, we also then added some literature for people to start to discuss. So For example, in the beginning, initial feelings were those of frustration with the perceived barriers to enacting occupation and justice-centered practice. We were trying to implement justice-centered practice for our clients. But as justice-oriented practice came up more, we started focusing on literature about occupation-centered practice and occupational justice. And it was at that moment that I realized that we were the ones who were feeling marginalized and alienated from what we wanted and needed to do every day. And I was like, oh my goodness, we're experiencing occupational alienation here. And so adding this research and literature to those discussions really led to a deeper theoretical understanding of what was happening. And so when the community of practice scholars started deliberating that literature and understanding the type of practice that they were trying to improve, it became very clear to all of us that we were experiencing this occupational alienation in practice. And so before I talk about the findings, I will say, with all of this data, the reflections from the individual researchers, and also the recorded biweekly meetings, we went through a process of analysis. So Nancy led some workshops on how to engage in analyzing data and coding data. And so we had a pretty rigorous process of individual coding, bringing codes back, reviewing codes, then Nancy and I would review the codes, bring our thoughts back, and we continued in this iterative process until we kind of came to this point of seeing patterns and seeing what was arising for the therapists in terms of understanding how they were experiencing this occupational alienation in response to what we had then identified as hegemony in the practice context. This accepted way of doing things because we were practicing in a very risk-averse, very fiscally driven environment, and we're feeling all of those feels that were mentioned in terms of feeling devalued, feeling demoralized. And so the finding story is composed of these three themes that demonstrate a range of responses that occurred when a community of practice scholars intentionally and critically examined their practice. So in taking up Wilding's call to engage in questioning of the taken for granted dominance of medical discourses upon their practice, this community of practice scholars set out to become more occupation and justice focused in their practice. And in the process, they became aware of the impact of hegemony on their practice, leading to their own occupational alienation. And as Wilcock described this, occupational alienation was apparent as the cops described how they felt powerless, frustrated, isolated, and in many ways estranged from occupational therapy. So the themes staying afloat, sailing away, and making waves are kind of a narrative of nautical themes that we felt really represented the experience as well. So the first theme, staying afloat, was when members of the community of practice scholars expressed that becoming aware of hegemony made them at times feel that they were just staying afloat. For some, this was expressed by going with the flow and working with the existing systems. And given personal life situations, including the disruptions that they were experiencing with the COVID-19 pandemic, the occupational therapists noticed that they just didn't have the bandwidth to make changes on their assigned unit, and some of them even actively avoided being there. One said, "I have to prioritize my time and desires at work. I realize I have little bandwidth for change because I tend to prioritize productivity over change." Again, that pressure, that accepted, this is the most important thing I should be doing, and putting that as my focus. And then in these feelings of isolation and frustration and feeling devalued, one therapist noted simply working with your head down and commented that was a valid protective state. The next theme then, sailing away, the experience of feeling undervalued, frustrated, and trapped by context, as one therapist said, also led to a need to detach. For many of the therapists, this meant leaving the practice context, including me, for whom the hegemony inherent in the mental health setting had really consistently been a source of dispiritedness for me, especially having come from a universal healthcare system in Ireland and then coming into this system, this biomedically driven, fiscal oriented and risk averse setting was really, really challenging. And so I sailed away to Duke. Other therapists distanced themselves by turning their focus toward where they could use their expertise to feel like they could have an impact or feel like they could make a difference. And one therapist said, I applied for an opportunity to increase my presence in occupational therapy at the state level. Despite my conflicting and increasingly tight personal schedule, I'm still very motivated by this position. Again, motivated by the thought that maybe I can use my occupational therapy expertise for some good. And then for others, sailing away was more of an emotional detachment. While the therapist understood what was needed to change things, for different reasons, they just didn't feel in a position to invest. And so one said, for some of us, this practice-based inquiry process has led to seeking out a place hundreds of miles away where they can practice in a way that is fulfilling and in alignment with their personal values and principles. Others bide their time while searching for work opportunities that have less moral distress and more opportunities to make meaningful changes. We are left to find ways in which to work around whatever is in our way. And then the final theme was making waves. For some occupational therapists, the contextual challenges to personal values and professional identity and their awareness of the system's control motivated them to take action or become fired up and emboldened to make waves. And very early in the reflective process, some of the occupational therapists began to understand how hegemony was constraining occupation and dampening the values that led them to become occupational therapists in the first place. They were very aware of occupation as a unique, powerful means of improving mental health in the acute setting and were seeking opportunities to demonstrate this to clients and to colleagues. And with growing recognition through the PBE process of, quote, all they were doing to stand in the way of better human experience through simple yet powerful engagement, end quote, and growing awareness of doing things because that's how we do it, the occupational therapists found ways to make good trouble, borrowing from civil rights leader John Lewis's movement and represented here as making waves. One therapist said, I've been getting more firm with doctors and other providers because I'm realizing that my job is important too. And what I'm doing is often probably more important than whatever 5-minute conversation they are going to have. Yesterday, I told a doctor to come back so I could finish my eval and felt so empowered. Another therapist said, my decision to take a patient to the coffee shop, the courtyard, was minor in the sense that there was arguably no harm done. Certainly not to the patient, likely quite the opposite, beyond the violation of a rule. But it was major in that it was a moment in which I chose to embody my values as a practitioner rather than incorporate values that ultimately ring hollow. The second quote clearly exemplifies the ethical tensions that therapist experienced in making a decision about doing or not doing what was expected, or following or not following the rules, deciding to seek forgiveness rather than permission, and evaluating the risk of harm from the perspective of the practitioner over the system's understanding of harm, engaging in mindful reflection and deciding to align his practice with his moral character and values as an occupational therapist for the good of the client.
Okay, so we would like now to take a minute. Those of you who are alumni of our program know that we love reflection. So we'd like you to reflect on your own practice. So what systemic influences in your own practice might lead you or have led you to think that's how we do it? And some of the things you already put in the chat may be, in fact, be those. We're curious about, have your responses been similar to those we have presented? So how have you responded to those ethical tensions and the feelings of working in hegemonic systems? And then lastly, are there any actions you have taken that you are comfortable sharing? Because we want to make this so we can think about different kinds of strategies to, in fact, counter hegemony. So we'll pause for a minute here.
I see open to private practice. That says sailing away to me. I'm not sure if that's how you experienced it.
Administration is changeover, so finding workarounds. letting them rest anyway, making a case for not doubling patients, ask the doctor for OT orders.
Well, people have mentioned about stepping up as a member of a leader of our education unit. I can't ethically do my job as an OT within broken schools. So kind of moving beyond a lot of people transitioning into settings with non-traditional roles as OTs, as consultant or in other ways. Consistently talking about our whole client and their occupation. So really using the occupational language to, as Lynn Wakeford mentioned, divert the assumption that what we do is like fine motor or handwriting, and people are starting to get it. Yep. Directly addressing ethical concerns at meetings and getting a large audience at once to consider the issue, right? Working in a role without the official OT, right, title. Sailing away to community-based practice. I really relate to the ask for forgiveness rather than permission approach. Yeah, it's that sort of that taking that risk, right? Mary Beth, any ones that strike you?
Yeah, I like you, Lee. When I'm told this is how we do it, then I would ask, how is it working out?
That's great.
Clearly it was working. Would not have asked for my service. Yeah, this is how we do it. That I interpreted that. You can interpret that two different ways. Like, this is how we do it because the system is saying this is how we do it, or no, this is how we do it.
That's right.
So I like that. That's really kind of an active, I suppose, making waves, really. Let me show you how we do it. Yeah.
Yeah. And just really advocating, some of the time about advocating for shifting a percentage of their day to focus on program building, education in the NICU.
Yes. You know, it's interesting, those team attitudes that Katie mentioned there about people who can't live independently on a housing team, and then taking the action to find a policy that actually contradicts that and helping start a work group on the issue. Those are amazing advocacy and actions that can really kind of begin a movement to counter hegemony. We appreciated in talking about this work at the SSO conference in Durham, and having someone there from a country that really understands hegemony in terms of, I suppose, racial identity, and really appreciating that actions toward countering hegemony require a movement. While making waves is something that gives us a sense of purpose and gives us empowerment and gives us a feeling for a second that what we do matters. Collectively, we need to bring that into a movement, because so many of the things that you guys are writing in there is just, is just a system that has been mandating us to practice in particular ways for so long. And I don't want to resign myself to thinking that it'll never change, although I'm sure that many of us feel that way from time to time. But I like that approach where you're being strategic about your efforts, and in a ways that makes a bigger impact.
Exactly. Yeah. All right. Thank you for sharing that. So we wanted to just bring up a few points. And that the reasons, for the practitioners' responses to hegemony are likely, multifactorial and complex. We recognize there are times in life where we may be better positioned, whether it's financially, maybe in our earlier part of our career versus me in my later part of my career, where I feel like I can take some more of those risks. So I think just recognizing the complexity of these different types of reactions, and that there's really no judgment, right? People need to do what they need to do at that particular time. The other thing that we really saw within our research was that the practitioners' responses did change over time. So for some at the start of the study, they were quite reluctant to take a stand. But as we had more conversations and they felt like there was a community around them to support them, we saw some shifts in how people responded. Other people who had been probably taking a stand for a while were, in fact, experiencing some of that burnout. So I think just recognizing sort of those where we may be in our process of countering hegemony or responding to hegemony will be very different over time. And so we also recognize that taking a stand against hegemony is not without risk, and in fact can create additional ethical tensions. So as we talked about the example earlier, and we heard this multiple times about, the tension that the practitioners felt when they did, in fact, take a stand, take a strong stand, talk to physicians or others who had that power. We really just want to acknowledge that it does come with risk. And again, there's that weighing out of how much risk one is sort of willing to take.
Yeah, that was one thing I didn't mention, but somebody mentioned it in the chat actually, that those responses, were varied across time and across therapists. Sometimes, as Nancy said, some were motivated to really, especially if something got particularly challenging and they felt particularly passionate about it, maybe, making some waves there. But then sometimes, for different reasons, different days of the week, you just don't have the energy, you just don't have the motivation. And so it was then that they would maybe just stay afloat or begin to start looking for ways to sail away, to give them a sense of, I'm not stuck here, I don't have to be here forever. Even if they didn't leave, just that whole kind of envisioning sailing away to something different could have been a form of support for people. And I think the person who did kind of, decide to ask for forgiveness and not permission, it's interesting. I do think sometimes for these practitioners in particular, there was a sense that people in decision-making positions at, management level or unit supervision level didn't appreciate the qualifications that the occupational therapists have of assessing a person's mood, state of mental health, and being able to do their own risk assessment. And so I think that having that collective process really was motivating for people. And all of the literature on countering hegemony or trying to change systems says the same thing. It needs reflection and it needs a collective approach. And so I think that the practice-based inquiry with a community of practice scholars who are all passionate about occupation was definitely the way forward for us. It would obviously need sustainability to continue to keep the momentum, and that in and of itself can be very difficult.
Absolutely. So we, based on our research and our own personal experiences, like to advocate for us to do various things. So one of them is that we can have more discussions like this, discussions about systems, discourses, and practices that create ethical tensions in our everyday practices. So within educational systems, both Mary Beth and I are in educational systems, having these open and frank conversations with students is a really, really important aspect of creating the next generation of practitioners who understand how these hegemonic practices actually happen, and to have strategies for how to counter these hegemonic practices. But I think just really, again, having more open discussion about it, having times for students to come back from field work and talk about some of their own ethical tensions in ways that are respectful and understanding of the systems within which these practitioners are working. Mary Beth, anything you wanted to add about the educational piece?
No, I mean, I think you covered most of it. The only thing, no, but I will add,
Yeah.
you know, we talk about advocacy an awful lot in our curriculum now, and it is kind of a way to meet the vision of enacting justice and enabling participation for all people. And I think that not everyone believes that OTs should be advocates, and certainly if not at the macro level or the meso level, I think we definitely are advocates at the micro level. But I think we need to prepare students to create change at system level. And the only way to do that is to talk about advocacy and to have these conversations about these accepted ways of doing that aren't going to change if they're not challenged.
Absolutely. Yeah. So we also advocate for, as Mary Beth said earlier, the creation of communities of practice. And I know those are becoming more popular, but it is in those feeling a part of a community where we can, again, have these kinds of conversations. Journal clubs, somebody in the chat had mentioned about using evidence to counter some of the ideas that maybe we're feeling pressured to do and be in a certain way, where we have evidence that shows that some of these practices actually aren't effective, and that there are alternative evidence-based practices that we can and do implement. We also advocate for this idea of collaborating with those like Mary Beth and myself to do practice-based inquiries. While it does require time, and as Mary Beth said, the time to do the reflections, I think everybody who participated in our particular study and in these kinds of practice-based inquiries have been happening around the globe, actually, really report that it's a very satisfying experience, both at the for individuals, but also that collective reflection, to know you're sort of not alone in it, to have sort of comrades who can pick up when you're not feeling it, who can carry the mantle for you. So this collective idea is a critical one. Next goes along with this, but we really need to be publishing more and writing and telling stories more about what it is that we are doing, that we are to counter hegemony, to just put that out there and be frank. I mean, I think that story about, I'm going to go ahead and do this, or I'm going to stand up to the doctor, need to be told. I think they're really powerful stories that can inspire others. So really having guidance for practitioners for different ways that they can take a stand. Mary Beth, do you want to talk about making ripples? Because I think this was interesting how this came up.
Yeah, I think, in continuing conversations with some of the therapists that were involved in the study, and some working in the setting that were not involved in the study, we kind of talked about, staying afloat is not a bad thing. There's no judgments on any of these themes. There's no judgments on any responses to the hegemonic system in which you're practicing in. And in fact, some of the therapists felt that staying afloat was a necessity at times in order to be in a position to make waves at a future time. And also that a category called making ripples might look like those little everyday acts that push back against the status quo, but do not in isolation make a big or maybe noticeable difference to anyone other than the OT, or perhaps the OT and the patient in front of them. But those making ripples can keep OTs motivated and believing that what they do matters, particularly, as Nancy said, when they share those moments with another therapist and get the feedback and validation. And then you're not just making ripples against hegemony, but you're making ripples toward a collective response to challenging some of these system policies and procedures that are leading to burnout and frustration and disillusionment and all of those other pretty heavy responses.
Yeah, so we would love to hear if you have other ideas of things that we individually or collectively as a profession should be advocating for so that we can avoid occupational alienation and really highlight the full value of what occupational therapy can offer. So if you wouldn't mind putting your thoughts in the chat again, we would really appreciate that.
I also think if we can save this chat, there's a lot of good stuff in there.
I know, we should publish this, right?
Good.
Nancy, do you mind saying the question again and I'll type it?
Yeah, if they have any other thoughts of actions, things that we could be advocating for, ways to, as within their own practice sites, that they could advocate for change.
Yeah, yes. Everybody who doesn't understand what OT does, the minute they understand what OT does, they're like, oh my God, that's so amazing. It's like, yeah, it's been amazing for a long time. Why is you're only finding out about this now?
Yeah. Yeah.
Yes.
Yes, calling reps. Yes, we need to, again, our political action really does matter. Staying up to date with what are the latest issues about Medicare, Medicaid, right? Social Security, benefits, those things. Yeah.
Yes, yes. Yeah.
Yeah. Joining unions. Yes.
I think interprofessional education can also be a
Yeah.
very good foundation for understanding each other. And, it's funny because one of the conversations that came up in one of the reflective sessions was how it would be amazing if other disciplines had this kind of reflective process to really think about their own practice. So that would be a really cool research study to do an interdisciplinary practice-based inquiry. Wow.
Yes. Yes. Yeah. So if anybody out there is interested in perhaps partnering with me and Mary Beth around some practice-based inquiry that could be done. Yeah, it's just all this idea about the sharing our knowledge, right? Putting it out there, educating physicians while they're in medical school.
Yeah, this non-traditional OT, I mean, I know what it means and I know why we say it, but I just feel that everyone's perspective of what a traditional OT is doesn't understand all of the things that OTs do that make us non-traditional, if that makes any sense at all.
Yeah, yeah.
We've been
Yeah.
non-traditional since our start, really, I feel.
Yeah. Yeah, knowing the actual policies, right?
Yes,
It's really,
yes.
yeah.
Yeah.
These are great. These are great. Awesome. All right. Well, we want to wrap up, but we want with one for last idea, and then we'll open it up for questions. So, slide. All right, Mary Beth, you want to give us our conclusion here?
Yeah, I think this kind of brings us full circle back to what I was saying about the debate going on right now over the revision of the Code of Ethics, and the belief that not all OTs should be educated to be advocates and changers of the system at macro level. And I totally get that. I get that it's fair. It's a pretty big fight, and so it does take a lot of energy. It takes confidence. It takes real belief in the power of occupation. And so, at the end of the day, you have to be satisfied that you're doing what aligns with your moral compass. And understanding that not everything that is faced can be changed, but nothing can be faced nothing can be changed until it is faced. And so it's fine to decide that the system is the way the system is and you don't want to work against it. But that's not going to incur any change. But that may protect you. And that may stop you from getting burned out or banging your head against the wall or whatever metaphor you want to use. So I appreciate that there is a range of responses, but I also do feel that we have an obligation to ensure that everyone knows enough to make an informed choice.
Well, thank you very much. We wanted to leave the last 5 minutes or so for some dialogue. So you can either put a question in the chat, or Sarah, we can unmute, is that right?
And maybe stop sharing so we can see faces or at
Sure.
least squares with names on them.
Well, yeah, I'll have to reshare, but
Oh, okay.
Yeah.
Oh, yeah, that's okay.
Yeah.
Sorry about that.
right.
Yeah. Yes, I like it. A bigger boat to sail together. I want to be in your boat.
That's right. That's great. That's great.
If anyone cannot unmute, just type in the chat and I can try to unmute you.
Yeah.
Let's see. Any questions, other comments, or differentiate between moral injury and burnout? So that's an interesting question, because they're often used interchangeably, I think. However, my understanding is that, they are distinct in some ways too. So, moral injury is when your deep values and beliefs, really have been violated. It's an injury, right? Which can lead to feelings of ethical distress and can lead to burnout. But burnout is really more of has an emotional, physical, mental exhaustion piece to it. That moral injury may not. And it's really caused by excessive stress, the burnout piece. But I think they are used somewhat interchangeably. But in literature, you'll often see people trying to define those two concepts as distinct.
Does moral injury have a component of like knowing what the right thing to do is, but not being able to do it?
Right.
And obviously being in that situation time and time and time again is quite likely to lead to burnout.
Yes. Correct. Yeah. Yeah.
There's a question about, will your research be published?
It actually has already been published, and let me see, is this the one that's in the references, Nancy, or is this the one? No, I think
we've had two publications. And in our references, we have this latest one, which is really what this talk was based on, which is the occupational therapist's experiences of hegemony in mental health settings. So this was published in the Scandinavian Journal this year. We also have another publication that was in AJOT in 2024, I believe. So yes.
Yeah, I think maybe that was 2023. I think it's at the start of the.
Oh, yes, it is 2023. Yeah.
Yeah.
Yeah. So that was an AJOT. Yeah. Well, we want to thank you so much for attending this evening. So two pieces of business to end. First is there's the QR code for the survey, and it will lead you, once you've completed it, to a certificate that you can add your name to and submit. We can't guarantee that it is an ethics credit, but should be. And there's also the link there. And then secondly, we are so happy that we can continue to provide this ethics event as a free event open to the public. But we continue to need support to be able to do these events. So we've given the link here to support our future events. The ethics event is one event that we do annually, and the Mitchell Symposium is another. So yeah, if all $5 would be great. We would accept any donations. So thank you again for participating this evening and for your we will save the chat so that we can read it and consider. And, maybe one of our next steps would be to publish in OT Practice or some other way that we could have a wider reach than in an academic journal. So getting me thinking about things that we can do. So I hope this leaves you with some new thoughts and ideas to take into your practice. And we hope you have a wonderful rest of your evening.